before New York City shut down. And we looked outside and saw the streets quiet, and hopefully New York's opening up well, that we're all now wearing masks and have it, and we keep that momentum. So thank you again for having us. Dr. Stephen Rudin is also in New York City, is a colleague I've got to know through IVA, who's really a connector, connected Arthur and I, and connected Dr. Rudin. Stephen's been joined us as a strategic advisor in the past 6 months. And I thank you all the time, Stephen. You look at things differently, your experience from not only med school, but with the business acumen of a fellow entrepreneur. I'm glad to have you on board.
Thank you, John. Few things make me happier than to be working with Mitre. I have to say, it's there's nothing involved with the evolution of this company, and as an investor, as a board member as a board advisor that I don't enjoy. It's terrific opportunity and great work that will save lives and do well.
Well, thanks. That's a nice segue, Arthur. With you talk about making sure everybody can log in. Would you advise us now to just let us know when you think we should start to
I think we should just go right ahead. You're in good shape.
Okay, great. So these presentations, we're all learning how to do them well. I appreciate the folks that have come on board, and I want to make sure you feel free to ask questions. We want to address them. It's the reason we're here and the reason we have a collaboration of folks together, and it makes it more interesting for everyone involved. So I'm going to share, we have an hour. I'm going to share first a short video that some of you may have seen, and I'll narrate it, but it's going to walk us through the opportunity initially and give everybody a high level aspect about the entity and also about the team. I think
I'll give you a heads up when we can see it. There we go.
Great. Thank you.
There we go. We got it.
So there is a how about there? Is it up?
Yep.
Oh, it is. Okay, great. So at Mitre Medical, we're really focused at delivering a fundamental change to cardiac surgery, and that's the elimination of the need for open heart surgery in a select set of patients. This isn't a global solution, but it's a massive fundamental problem. And it's called functional MR, and it's for patients that are at risk for heart failure. Now, what happens when you go into heart failure is your heart enlarges, and particularly the left ventricle. And when it opens up, it takes with it the mitral valve. So you have an enlarged left ventricle and a leaky valve. The standard of care now is to fix this geometry problem involves slicing open the heart and stopping it for 1 hour. And then they sew in a ring, and that ring provides a geometric overlay to control that geometry. You're just restoring geometry. If you look, there's no component of the device that's a standard of care that's touching the blood or changing any function. But this procedure triples the risk of stroke, and it doubles the risk of AFib, just to get inside the heart to sew that ring in. And so the surgeons that developed the Mitral Touch were really looking at how to do this from the outside. From a size standpoint, from the market, less than 4% of these patients are going to get treated over their lifetime, even though 70% of them are in heart failure. So this is the worst prognosis patients, and there's nothing for them. I was just saying, the surgeons that looked at trying to change the geometry from the outside would be able to eliminate the need to cut open the heart and to stop it. And that's exactly what we do. I'm going to just back that up so I can walk through that. So we're looking at a mitral valve in an animation from the top. The ventricle is below, the atrium is on top, and the valve just isn't closing, and the representation of it leaking is the blue-colored cloud that's coming at you. And so if you use this same shape and put it on the outside of the heart, and then twist it to bring in the ventricle, you've both treated the leaky valve and the ventricle without stopping the heart. And that's really a definition of a disruptive approach, because patients want a less invasive treatment, surgeons want simpler and faster procedures, and the hospitals and the payers want shorter hospital stays. We're taking days off the time you're going to be in the hospital. We're also taking days off the time you're in the ICU. And as COVID is showing us, that's a very important room to get patients in and out of. Now, we've done this and verified this in a clinical series in Europe. We did 5 patients. We followed them for a year, and Dr. Isaac George from Columbia Presbyterian presented the data at the virtual AATS just last month. I'll go back over that. And the FDA has approved us to treat patients. In November, we got the approval. The paperwork is up and running by the time COVID hit. But we've now successfully gotten through that, and that's really the opportunity that's in front of us. A little bit about the approach is I was fortunate to be in the first class of BioDesign taught at Stanford, where the program was initiated. It's a repeatable process. This is the 5th company that I've been at the C-level. We've rewarded investors with over $600 million in shareholder value. We've had acquisitions very early on, half of them with less than 10 patients treated and half in early US approval. So we're really looking forward to doing this again for our investors in Mitre Medical. And in particular, the big story we're looking at is to get all the way to FDA approval is a $12 million fundraise. In that scenario, with the existing comparables and the appetite for this space, it's a 10x potential return, and it's a $1 billion market. So there's been over $3.5 billion in acquisitions in this space, and there continues to be need for devices and approaches. And in particular, Mitre is focused at doing this for the cardiac surgeon. So with that background, there's off the link off the website, there is that video you can find for further reference, but it just gives us a starting point. Are there any questions on that?
I would just to be super clear, as someone that does not have the background, but obviously I've known and seen this, is that this is the device, and the device is the thing that has created the opportunity to eliminate a lot of the time that stops the heart, the cost of open heart surgery, and the elimination of actually slicing the heart open, which is essentially the only thing that can be done now for these type of patients.
Correct. Yeah, thank you. So these patients, there's hundreds of thousands of these patients, and less than 4% of them, once they're diagnosed, are going to get treated. And it's not because the surgeons don't want to do it, because there's no device that really answers it. So if I may, I can walk through the device. I'm going to come off the shared screen and show you the device physically.
Okay, we can see you.
Okay, great. So this is a mitral touch. So it's curved like the existing rings, and it's going to slip around. This is, we're now training on simulated hearts, beating hearts, of which this is not a real heart, it's just modeled after one. And you're going to take the device, instead of slicing this open and stopping from beating, we're going to slip this on and tack it into place. Oops, sorry, I'll hold it up. But so just, it wasn't meant to be a big demonstration, just to show you what we're looking at. So as you might imagine, this is a very high margin product for the return, and a huge economic benefit to the patient and the hospital. And that margin then goes to the shareholders. And I will go here. I'll share again, and we'll just walk through.
While you're doing that, just to be clear, the chest cavity needs to be open to put this in, but you don't need to stop the heart for all this long period of time that's normally the case, and that's one of the biggest advantages.
That's a great point. So there are almost 200,000 patients a year that go in for a coronary bypass. So those patients are already on the table in the OR, and their chest is open. A third of those patients, 30% of those patients, have this other condition at the same time, and they're still not treated. So that's the early adoption opportunity that we and the FDA sees, as well as the strategic partners. So what does that mean? We don't have to go run a TV commercial or a radio commercial to look for patients. These patients are under the surgeon's care in the OR, and they're not getting treated. It's just a shortcoming of us from device developers to provide a new and innovative solution. And that's what we're taught at BioDesign. Understand where the problems are, bring in a simpler solution to improve outcomes at lower cost. And that's what we do for each company. Okay, any questions? So we're looking at this, thank you, Arthur, for helping guide the discussion. So where are we as a company? We believe we're within 10 patients in our recently approved FDA trial, that we're 10 patients away from getting a structured deal. I can walk through what that structured deal is, what those are, what the comparable deals are, but there is a rather imminent opportunity for what we're doing, even in light of COVID. And we can talk about why that's the case. As I stated before, I'm fortunate to come out of the BioDesign network. One of the big advantages of being in that program is you get to work with world-renowned clinicians. And Dr. Michael Mack is our senior clinical advisor, and he has no peer in the literature in research for heart disease, for surgical or catheter treatment. We're just really fortunate to have him on board. So the present state of the care, as we talked about, triples the risk and doubles the AFib. But I want to show you sort of in a little more detail what we're talking about. Now, presently, what would be the standard of care if you went in for a bypass and you had this disease? You would have this done to your heart, right? So I think you can see me in one of the windows. So this is that same view. This is the top of the atrium sliced open in a patient to just change the perimeter of that valve. That additional step that you're looking at in this picture, after 40 years, this step alone is another 56 minutes that your heart is stopped and opened, versus just being able to slip it in from the outside. So that's the disruptive transformation. It's the same materials, it's the same geometry, you've just zoomed in and you put it on the outside. Simple and disruptive. Now the video may make a little more sense for folks that haven't seen it. So instead of slicing this open and stopping it, we're just going to slip it on from the outside. And in the side view, you see that it's rotated down onto the ventricle, and that protects the ventricle from dilating further. Now, we now know from the clinical research that a leaky valve, represented by the blue cloud that's shown in this video, that is very symptomatic for a patient. You can't walk up the stairs, your legs swell. But what's really killing people at a higher rate is the dilation of the heart. So you want to stop the leak, but you also want to treat the ventricle. Once again, if you want to be disruptive, there's no patient that's going to say, no, please stop my heart and cut it open. When you can try our device first without attaching it to just see if you get good enough results. You always have the option to do any other procedure, but we would be the first test you would do. There's exceptional reimbursement in place for the device for high margins, and the hospital wants those patients out of the ICU. LOS is a shorthand for length of stay. The surgeons is an interesting aspect because to do the standard of care is a very complex procedure. It takes an extra hour because it's not trivial. And as a result of that, you also have a burden of technique where surgeons will do a bypass, but will not opt to go any further because of the level of complexity. So you allow them to treat more patients right away, and you increase the adoption. Arthur, you were touching on this. So our initial target market with the FDA is what we call FMR in the OR. So this is a patient that's already on the table, his chest is open, and the surgeon wants to do everything they can do safely while they have the patient in the operating room. And the patient doesn't want to come back either. They want everything they can do. And still, there's only 4% of these patients get treated. Now, the bigger patient population, and for every exit we've had, you always have to have some bigger patient population that's within reach. And that's heart failure standalone patients. It's a little technical to go into now, but it's for patients that don't need, that aren't on the table for a bypass, and their sole problem is a dilated heart and heart failure. And we can, if folks are interested, we can talk about that later.
John?
Yes.
I think it's interesting to mention as a corollary to this excellent conversation, this moment, that when you see a new procedure that's going to offer something, and of course also offer a potential larger opportunity, the limiting factor is what kind of wondrous surgeon can do this. And really interesting that Dr. George brought up, it's not that I'm looking for another career and I think that I can train overnight to do this, but the really interesting thing was, as he said, there are 15 masters of the mitral valve in the country. People who you think if you had to hit the standard of care, you got a fighting shot at it. But that you couldn't expand to an enormous market for that. But a really excellent, a really good surgeon trained in this technique will be able to do it. You won't have to have so widespread use of this opportunity will be able to be possible because good training will be sufficient for a good surgeon to do this procedure. You won't have to be the once-in-a-lifetime surgeon somewhere in the world. And I think that was a very encouraging thing to hear from somebody as talented and as kind of both engineering and surgical talent as Dr. George, assessing this and saying, no, this will be able to be accomplished well by good surgeons.
That's a big part of the reason that we got interested in this because, and thank you for bringing up, so in New York City, you've got Dr. Isaac George at Columbia, and then Dr. David Adams is the #1 mitral valve surgeon in the world, and he's just down the road, and he loves this as well because his approach is they've been talking about 20 years to how to improve this procedure, and the need to help the ventricle is you can't do it from the top unless you're an absolute master and you start sewing down inside the middle of the heart from the top. Every one of the masters sees the adoption to their colleagues faster as well. So when we did our first-in-man patients, our surgeons did 10 implants and explants on one animal in the morning and said, that's all we need. So that's folks that hadn't seen it, and we're going to treat their own patients. That was a Friday in Paris, and they were going to treat their own patients Monday in Lithuania. And so if you're familiar with the complicated technique, you even more embrace how simple this is. So we did 5 patients to validate it. We waited 6 months, took that data to the FDA. The FDA took 9 months to respond and approved our clinical trial in November of this year. And we've been doing paperwork now for quite a while, but the centers of note, we have Dr. Mack's center in I'm going to pause this for a second. It's going at its own pace there. Stand by.
Okay, it's paused now.
What's that?
I was just saying it's paused now. I know you can see it too.
Okay, great. Thank you. So we're now, the first cases were done in Lithuania, and Drs. Mack and Dr. Vino Tarani, who's out of Piedmont, just outside of Atlanta, Georgia, were the advisors for that. And we're looking at, in the inclusion criteria in the center section, you're talking about patients already in the room for cardiac surgery that have FMR, which is known as functional MR. We did a handful of patients initially. And the big question we were really looking at is, you're going from animals to sick patients. You want to do a small set of patients, make sure you have a durable result. We waited 6 months to go to the FDA. We then took the 1-year results to them as well. But we got some tremendous results. So this is a little nerdy, but there's a couple of key points here. You want to make the heart smaller, and this is the direction you want is down on this graph. And this is our patient experience. And additionally, when you look at the standard of care, this is 40 years into this field of mitral annuloplasty rings, 2 huge trials done. It shows that after a year, you're still only half the improvement that we can provide. And like I said, that's 56 minutes. And we already had 2 of our patients done in 30 minutes. And as a new technology, to be fast early is an excellent, excellent sign. Because like in iPhones and in cardiac surgery, easy wins every time. So we are raising capital to replicate the results in Europe in the US. There's an exchange rate, as we say, for the strategic partners that you want to get early and quickly to treating patients in the US. And we're doing that. So with the FDA support of our trial, we have a protocol approved for 10 patients. We're in the Baylor Center in Texas with Dr. Mack. We're in Piedmont with Vino Tarani in Atlanta, Gaurav Alawadi at University of Virginia, and additionally in Mark Russo in Rutgers. The reason I bring those up is COVID is now making it a really interesting and challenging situation for us in our field. We were fortunate we had not started our trial yet. We had started the paperwork. So we were able to continue the paperwork over the past couple of months. But now we have centers opening up. So we believe we can start treating patients in July and August. The nuance is in the COVID world that we're in different geographies and we're not in states that are having big recurrence, because those hospitals in those states, in Texas and in California and in Florida, they stop their clinical trials so that all the staff can be dedicated to the pandemic. We saw it in New York and New Jersey already, but they've learned their lessons. So those centers are open. And similarly, we're on phone calls today to get local trainers that are within their local geographies. So we're really fortunate that we hadn't started the trial and had to stop it. So we didn't build a team and have to pay for them for the past 7 months. But that's what we're going to be doing with the capital. The small safe that we're talking about, which is 800,000, is still open. That we're going to grow the team, and we're going to treat these 10 patients, and we're going to move our R&D a little more forward, because you get these structured deals because you have good U.S. clinical data and you've got some sizzle, and that's the formula.
John, I may have missed this, but let's just recap. How much was the safe in total?
It's coming up. I just sort of wanted to roll into
Okay.
that, but we've raised, the company to date has been leveraged about 3.1 million in capital, and this safe that we're operating, that my capital is also in under, that's gone in, is for 1.6 million. So it's about halfway full at present.
Gotcha. Thank you.
This is the U.S. Trial design, which it's in essence the same as we had in Europe. We talk about the heart failure opportunity is, if folks know about Dr. Mehmet Oz developed a product which is now in the Abbott portfolio. It's doing tremendous results. It's called the Mitre Clip, and that's a heart failure only patient population. It's important to know that that product, which is now driving 2% of Abbott's top line, one product for one type of patient, that there's a bigger patient population that it's leaving behind that we think we can address, which is a bigger heart. It's a little more technical, but we can, if folks want to read some of the literature, I'm happy to provide. Our biggest value creation right now is touching patients in the US. But since we've been working in parallel, we're also in discussions with Japan. Japan and the US used to be the two most challenging medical markets to get into, and that's changed in the past 5 years. And it's changed because the economic burden of healthcare was so high, they realized they would have to innovate out of it. And it's really been fortunate for companies to accelerate access to markets. So we are in discussions to have our US patients and our Japanese patients be our first two approvals instead of the last two. It's a group called PMDA. It's their version of FDA, and we're in discussions with them about every 60 days. So we're in the process in multiple countries. Japan is a small country, but it's the #2 market for cardiac devices. They are particularly particularly expert at beating heart surgeries. So when they have to do these patients, it substantially increases mortality. I mean, and so they're really excited about us coming because their expertise, they have the most elderly and population in the world, and as a result of that, they have a huge amount of heart failure. So that's another piece of the sizzle. So we're looking at global markets simultaneously. We're fortunate to have some great strategic advisors, Dr. Rudin, who's on the call, Amr Salihia, who and I have done a pair of companies with, is really changing the model in Silicon Valley. And Nancy Briefs is in the Bay Area, in the Boston area as well. And Maria Saenz used to run the $2 billion cardiac surgery division of Boston Scientific. So we're really fortunate. I mean, you have to check all these boxes. You have to have the right advisors, and you have to have the right key opinion leaders to get comfort level from these strategic companies like Edwards or CryoLife or Abbott to pull the trigger. And this is the right group of cardiac surgeons. Dr. Mack, you just want this guy when you're sick. And then Drs. George and Dr. Tarani have been voted 2 of the 5 cardiac surgeons to transform from their peers, young surgeons to transform cardiac care in the next decade.
Hey, John, we have a question. If we could see if you are able to address it now, is that okay?
Please.
So Kimberly's asking, she said that this has been helpful. She said, are you in a position to share some patient follow-up stories and how they've been doing today?
Good. I like the empathy of that question. So we have a great story. We have an article coming out in Structural Heart, which is a journal. One of our patients was younger than me, so he was 56, a gentleman on the heart transplant list in Lithuania. His heart was bigger than this one, and this is a massive heart. He was off his heart came down 55, his heart got half, reduced 50% within 30 days. I mean, everything you could want for hope in a biomechanical response to helping that heart function came true for us. So this patient didn't have his heart stopped. He got a bypass. He got our device put on the outside. In 6 months, he's off the heart transplant list. And he was upset that he had to come back in for his 1-year follow-up because he was going to have to take time off from his construction job. And it's just, when I showed that case to Dr. Mack, he just stared at it and said, congratulations. And, you should be fortunate in your life to have people you really admire. And so that was a big deal for us and a great deal for that patient. Someone else said that guy should buy a lottery ticket every day, who thought he'd be walking around Lithuania with the state of the art surgery device. So did that, I hopefully think that addressed that question.
Yeah, it certainly is a perfect example. Are there any others that you might share since we're on the topic?
That one is big enough to we're writing it up as its own article. Yeah. Because when you get a performance like that, you're really starting to compete against not only transplant surgery, you're competing against LVADs, which is a multi-billion-dollar market. And you're treating against cardio resynchronization therapy, which is another multi-billion-dollar market. That's really that heart failure patient where they're just, if you didn't help them early, the heart just gets about 10% bigger every year. And so if you don't get to them early and they don't respond to meds, and about 30% of patients respond to meds with heart failure, then you have these patients they're really in a jam. And that's our growth opportunity, right? So because it's an interesting, we'll get it on the regulatory side about why we're going for which patients first. But here's the history of the company. So I came along with some colleagues and we funded it in December of 2017 with $250,000. It had already been licensed out from former branch of Boston Scientific. They had sold it to a company in Europe, and that company was not interested in the implant. So it was licensed out to the engineers who went to Stanford BioDesign with it. And I met them in late 2016. So in December, in fact, on my birthday, we closed the initial round. And enough work had been done that even with that little money, we treated the first patient within 12 months. And we immediately saw some amazing positive signs. So we put in another $1.5 million. We first put in 400,000, then we put in $1.5 million. We did more patients and we followed them for a year and really focused on the FDA requirements. Europe is a little friendlier. You can start treating patients a little earlier without, let's just say they're more aggressive. So we had to do a bunch of work to present to the FDA. And in 2019, we opened a safe for $1.6 million, and this we should spend some time on. That's the one that myself and Dr. Rudin have put our money in. So, but half of which is still open. So we got 800,000 of that open. You know, a lot of this additional time, we're telling our story to strategic partners. Intuitive Surgical, which is the #1 surgical robot company, had us out with Dr. Sam Balke to see if we could put this in using their robot. We did. It was an excellent case. Dr. Balke immediately wanted to become an advisor. But Intuitive Surgical is really focused on making its money in the prostate. It started out as a cardiac surgery platform. So they're there, but their growth, when you think about it, the business, they're growing into China is where their growth is, and in proctology instead of, or prostate cancer. AtriCure is a multi-billion-dollar company working on the outside of the heart for AFib. So we've collaborated with them, and they've really taught us a bunch about how to do beating heart models and these trainers that we have. And their stock is up about $1 billion since the new year. They have some excellent clinical data. You know, Edwards Medtronic, CryoLife, also in the mix at the same time. But what it's done is, our original plan is what's on this slide, that we were going to raise $12 million and we're going to go all the way to FDA approval. We have guidance from strategics that they would want to basically take us off the market. And what they do is they would provide the 12 million non-dilutive to shareholders, and we would still go and execute to get to FDA approval. The reason that big companies do that is because we're lean and mean, and we can iterate and move quickly, and that's not what they're built to do. What they're built to do is to sell product that is approved. So we have this interesting opening, and which is what we're really fortunate to be sharing with Arthur and the family offices, is this 800,000, we believe we can get through our 10 patients, and that those discussions, it may be all we need to get to non-dilutive financing. So what type of numbers are you talking about getting an exit? So I've sent out in the link, and Arthur has it online, you know, the $3 billion in exits in the space. When we think about a surgical exit, they're a little smaller than the interventional ones, unless they're in general, but these are comparables. So Edwards a couple years ago gave the money to Harpoon, non-dilutive, to go out and get its European approval, which it did do, and acquired the company after it had done its 30 patients for $100 million. And they have a back-end deal for milestones of another 150 million. And that's very comparable. We have a lot of confidence in that comparable. The one I've just listed is on the far right. On the left is a acquisition. There were 3 acquisitions in 2019. Cephia was bought by Abbott after less than 10 patients were treated, all overseas. It doesn't have a clear FDA timeline, and FDA timeline is important because it's the largest market in the world is the US, and you need, of course, FDA approval. So that's a really provocative timeline. Now I see we have 2020 listed for us. I think COVID's moving us to 2021 pretty clearly. But when we sandwich our deal to look at returns, we do Cephia on the low side and Harpoon in the middle, and then looking at a bigger deal on the high side. And the way we move from low, medium to high is a mix of the clinical data, the key opinion leaders you have to inform the the strategics and competition. So we're actively working the relationships to keep multiple parties interested. But that's how you move across that chart to just straight business. Get a competitive market value, and that's what we're trying to do. We believe that with the 800,000 and the safe filled, and for reference, the economics, the return on investment that's modeled in this center section is modeled off the $12 million of dilution at a $30 million pre, which would be a 42 post. So that's 27% of the company that we would dilute, and that would be either to a VC, which is or other investors. The folks that can move and look at this $800,000 safe, the return on investments, even on the low end, is greater than 14x. We have a lot of flexibility to negotiate after doing our first 10 patients with multiple parties to get a really healthy return. How we do that is our US patients look as good as our European patients. And we really respect the surgeons in Lithuania. We know they're outstanding, or we wouldn't have gone there. The aftercare, as soon as you're off the table in the US and Germany are the best in the world. So we have a great confidence in our surgeons and our objectives. Thank you. That was really the deck to walk you through it. We're talking about a $12 million raise. For folks that are individuals that are looking to get involved earlier with a higher return and a lower number, get to know the company. That 800,000 is in the safe at the capital terms that myself and Dr. Rudin have invested in. And we really look forward to making these returns, not only to the patient. I mean, it's just, I'm so fortunate to do what I do, but to return high value to shareholders, that's the community that we have. And that's why we're reaching out to see if there's folks that want to get involved.
So one of the things that you and I talked about that I think people would be interested in knowing is, suppose somebody takes a part of the 800 left or all of it, what is the path to liquidation or liquidity, and how long, and what's that look like?
So we expect you, thank you for that. So we expect to be touching patients in the US at the end of July or early August. You know, you get your FDA approval, then you get your hospital approval, then you get your contracts, and then you get your training. We're right on the edge of training, which is why I have these hearts with me. So we think we'll be touching patients in the third quarter of this year, and that we can have all 10 patients done by the end of this year, right? So that we would be in negotiations or solidifying existing discussions on a structured deal with that data in hand before the end of the year. And then to enroll, we're at the centers that we want. So then you do a pivotal study, which is another 30 patients for your FDA approval. And that conversation with our sites enrolled in all the contracts and the 6 months of paperwork, now that turns into 60 days. So you've got centers enrolling, experienced, high volume centers. We think that the rest of the patients are fully enrolled by the end of 2021.
Okay, that's helpful.
Yeah, so we would be in negotiations for the terms by the end of the year, and the terms would say, go do this, do your 30 patients, here's your return, here's what your payout is when you do the 30 patients, and then you have milestones on the back end off of revenue or getting approved in Europe or getting approved in Japan. So those are, in this slide, there's it says exits. I'll highlight, well, I can't highlight, but down the bottom it says exit, and there's an upfront and then an earn-out. So so the upfront payment is that initial in your pocket, and then you get the earn-out over time, and you negotiate the split of those. And of course.
No, go ahead.
Please, Arthur.
What's the comparables are very helpful. What's the competitive landscape look like in terms of other innovations or disruptors like this? Is there anything in the offing that you know about?
There are most of, with $3.5 billion in acquisitions, most of those have been on catheters. So to the interventional cardiologist, the same person that puts in stents. So they're making devices on a catheter to come into your arteries or your veins and reach into your heart. There's probably 60 companies going after that market. And that's a different customer. So we are focused on the cardiac surgeon. So we have that space to ourselves with one other competition. There's a competition called Coronova, which is if you remember a company called Thoratec, the first pictures of somebody carrying a briefcase and it's helping their heart beat. That's really what we call Stephen, you may remember the right term. I'm blanking on it. Not a destination therapy, but they're just waiting. You're just sitting on the heart transplant list. So that patient is way out here, right? So you need a huge clinical trial. You end up walking around with something that's sitting on the outside of your heart, squeezing it for you, waiting for a patient or a donor to provide a heart. So there are companies working on the outside of the heart like we are, but none that are trying to do this patient in this simple approach. So we wish them well. They're funded out of, I think well, anyway, I know their funding group is an outstanding group, but they're a much longer, more complex play. As you might imagine from this, our mentor at Dr. Yak at Stanford would say, keep it simple. And that's what we've done. We followed it here.
Yeah, for the someone like me, when we first talked about this, I'm looking at it from the backyard mechanic perspective and saying, well, why didn't anybody think about this before? Because you're just putting a clip and changing the construct of the valve, and it's just physics, right? But of course, there's more to it than all that. I recognize it, but it does, in fact, keep it simple, and not only will lives be saved and people will have better lifestyles, that you'll have a return on investment and a whole bunch of money because you're doing that. That it's like, I don't mean, I have no skin in the game, and everybody knows that generally. So I'm not trying to promote this in the terms of if it's going to help me, but it just seems so straightforward. What can you say about, and you don't have, I know you can't identify them, but you can say, or I believe you can say, that their strategics are under discussion, and that it's one would expect you to have discussions with them, and that they're happening, even though you can't say anything about where they are and who they are, right?
Well, I can't, right? And our word has to be good with our non-disclosures, and theirs has to be good.
Yeah.
We present the history of acquisitions in the space, and we provided it to your team for so it's online as well, and all the press releases around the space. I can tell you where we want this to go. as entrepreneurs, but as people that, in our field, we're innovating these. I have products in my parents from 3 of my friends. This is not an abstract exercise we're doing. We're trying to do something important. And I'll tell you, the BioDesign principle is repeatable for other investors. When you see that brand, it's a real brand, because these surgeons, the reason they haven't innovated is they love what they're doing. So they're doing cardiac surgery all the time. So you need someone from the outside to sort of look at it and go, well, why don't we try something different? Like, tomorrow I'm doing 2 surgeries. They're not going to try something different. You have to go and observe what they're doing and innovate and bring it back to them. And that's the part of the ecosystem that family offices is empowering in entrepreneurs like us. So we love Mitre, but we love this discipline in general. When we look at the strategics, we want to see the product get adopted. So the biggest strategic in cardiac surgery with the best background is Edwards. When you look at the most aggressive sales force that's really ramping things up, you'd go to CryoLife, right? So a smaller company, but really aggressively looking at changing the paradigm where they are in the mix. Abbott is committed to this heart failure patient from a catheter side. They have a small surgical division. So, we're trying to convince them that they shouldn't commit just to the catheter. If they commit to the heart failure patient, then we're a natural fit. So then they own the catheter treatments for heart failure, and they own the surgical treatments for heart failure. All of those are excellent companies. And, there's a number, we're in discussions with a number of folks in Japan. We have advisors for that because those relationships are new to me. I haven't done a deal in Japan. So we look at that, and then you look at Medtronic. If they have the most invested in patients in the equipment that they use if you want to do surgery and keep your heart beating, right? So we dovetail into them. And all of them are up to speed, and all of them want to see a U.S. surgeons walk into their room and say, I took the mitral device and I put it in my patient, and these are the results.
Your language is really instructive because you say we're focusing on the surgeon, right? So that for one that doesn't understand the process in devices, that's really instructive to me, because the surgeon's going to want the one that's going to decide whether this is something he wants to use, right? And then what's the consequence of, or what's the pushback, if any, once this proves out, as you already proved it out in Lithuania? Why wouldn't a surgeon want to use this?
I mean, you're right where our conversations are, right? So where are you from? And one thing I want to point out, in the past maybe 10 years, is so many folks on the call probably have folks that have done TAVRs, have had aortic valves replaced now from a catheter. My father's had it done to him with an outstanding result. That's a rapidly growing treatment to the interventional cardiologist. When these 2 surgeons or 2 physicians in the US and in collaboration with the FDA, if you're sick now, you go see a team. You see an echocardiographer, you see a heart failure specialist, a surgeon, and an interventional cardiologist. In the US, to get reimbursed, your patient has to be screened by a team. And so it's not like the surgeon can hang on to a patient that should get a catheter, or a catheter patient, people are moved across. Everyone in the US, and this is true in Germany, are now seen by a team, and they cascade out into their treatment options. And it's decided by a team. It's fantastic for patient care. There's no territorial nature. So we're just talking about the patients who have already been filtered into the cardiac surgeon who has this additional problem. And that's from a business development standpoint, if your device isn't delivered by a surgeon, then you don't drop into the bag, the sales bag of that sales team. And so that nuance of just working with the surgeon has really reduced our competition. And it's given us access to great surgical leaders because they see this void as well. So we're really filling a niche in an important bag in some very large strategic companies.
Totally makes sense. I was just dropping a note to everybody to ask for the last few questions here. We have to wrap it up here. Steve, you're on mute. Steve, you're on mute.
Yep. The outcome of that is you have remarkably trained. Are we still here?
You're good.
Yes.
You're good.
Well, the outcome of that is you have remarkably trained human beings making a decision about a procedure. You know, assuming in the foreseeable future that, you know, like you said, it's all heart surgeons, assuming that in the foreseeable future we don't decide to allow optometrists and nutritionists and chiropractors to do heart surgery, we'll continue to have amazingly trained people making a decision on whether to do something or not. And from the standpoint of looking at a patient, that's a true advantage as opposed to walking in an office and have somebody say, well, we see this a lot, and then wondering what else you should go and look. Team approach to this so that there's no possibility that you're not seeing and seeing the full spectrum of things is a huge patient advantage. Enormous.
Yeah, super.
I want to thank you, Arthur. We've had 200,000 come in since our last meeting from a fundraising. I realized I hadn't thanked you for that. So we've had good progress from the
You're very welcome.
first meeting.
Thank
I
you.
know that it's important that someone's helping make these connections. They're your connections. It's our story. And facilitating it in a safe and thoughtful environment is really needed and appreciated. So
Well, it's good to hear, and I'm grateful for your comment and appreciate it very much, and super glad that it's working. So and for you and Iva and Steve and Greg, all the folks really. So we do have to wrap it up. Thank you everybody for being here. We're gonna.
Is there any follow-up that you, sorry to interrupt there, is there any follow-up in the Zoom world now that you,
Yeah. So we're going to make sure that everybody who's on the call gets in touch with you, or you can get in touch with them, vice versa, and we'll make that available, whether they registered or on the call or registered at all. You'll have all that information and put you direct in touch with everybody. And our normal activities will cause that follow-up, and we're super glad to do this for you, and again, glad it's working. So this is a great story. I've always been fascinated by it since when we met back at the Baccarat, when we could buy each other cocktails, right?
there you go. Well, it's coming back.
That's right. It's coming back. So thank you, everybody. We're going to put this recording up also on our Family Office Insights YouTube channel. Thank you for sharing with us. The only thing you don't have more of, that is your time. That's sort of my closing refrain that I've been using. I really, really appreciate it. And I know this is so campy, but your heart is in John and Steve's hands. So peace. We'll see you again.
Thank you.
Thank you, Arthur.
You're welcome. Bye-bye.